talk about diabetes. Standard medicine has a diet for diabetics. That diabetic has 50 to 55% of all calories being carbohydrates. They want a low-fat diet, 30 to 35%. They're going to use glucophage, and I use a lot of glucophage to decrease the glucose absorption. That's why they're using it. I also know that it improves insulin resistance, and so that's another use for it. They use a lot of what's called sulfonylureas. These are medications that stimulate the production and the release of insulin from the pancreas. So if the glucose is high or whether it's low, it's going to secrete the insulin. And so one of the side effects, of course, is if you already have a normal glucose and you add insulin because it's forced by the drug, then the glucose is going to go low. The treatment for low blood sugar, all the diabetics know, is to take some sugar. So they start throwing in sugar, and they have this yo-yo effect with their sugars, which is very harmful. I have had a patient. I consider insulin in the blood the normal level about 0 to 5. 5 to 10 I consider borderline. Anything above 10 I consider this patient has insulin resistance. I had a patient that came in to see me with an insulin level of 30. Huge insulin resistance. Well, I didn't see her for a long time, and she came back and she told me her experience with her standard medicine physician. The knee-jerk reaction in standard medicine with diabetics is, we need to get you've got high blood sugars, they're in the 200 range, we need to use insulin to get it down. And they never will get an insulin level to find out if it's too high. And this lady with an insulin level of 30 was given high doses of insulin because got to get that sugar down. And she became a very sick individual, extremely high insulin levels. So even without knowing that a patient needs insulin, physicians will put patients on insulin. Amputation of vascular compromise, aspirin, 81 milligrams a day to reduce the clotting in the vasculature. The 81 milligrams a day is double the dose of what the research shows, and so you get twice as much aspirin in the stomach, which causes the GI upset. So what do? The basic problem with diabetes is the blood sugar is too high. So why would we have 150 to 250 grams of blood sugar coming in, of carbohydrates coming in, when we could reduce it and stop the whole process at the beginning? Prevention instead of treatment. So I will drop the carbohydrates to 60 to 100 grams, and now we don't have to chase it so much. Now we start reducing the insulin resistance. I do use glucophage. We use chromium, vanadium, biotin, DHEA, and testosterone, all of which treat insulin resistance. If any of these are low in the body, there will be a tendency toward insulin resistance and a rise in the insulin levels. And there are a lot of deficiencies in diabetics. Magnesium deficiency is present in almost all diabetics if they're not being supplemented. The B vitamins, especially vitamin B1, thiamine. Dr. Lonsdale keeps quoting the studies that diabetics lose 10 times more thiamine out of the urine than do normal people. Severe thiamine deficiencies, and thiamine will prevent some of the neuropathies. That with vitamin B6. So alpha-lipoic acid prevents neuropathy. And if there truly is vascular compromise, instead of cutting off the limb, we need to get these patients into a hyperbaric oxygen chamber. We've got to get them in chelation therapy, aspirin every other day, nattokinase, we talked about that before. So I hope you're starting to get a feel for some of the differences, the application of the different philosophies.